Hello, everybody, and welcome to the third in our series of MycoClinics, which are organised by the MRC Centre for Medical Mycology at Exeter University. For those who haven't attended it before, these are clinical expert presentations of case studies with diagnostic considerations and follow-ups. Today we have a very esteemed expert who's going to talk about invasive candidiasis in the ICU. His talk will be about 30 minutes, and at the end of that, we will have a 30-minute questions and answer session. If you could pose your questions in the Q&A box, we will be reading those out at the end of the presentation. And today, Professor Peter Pappas has kindly agreed to present for us. As many of you will know, he's an internationally recognized expert in the epidemiology, diagnosis and treatment of fungal infections. He's a professor of internal medicine and infectious diseases at the University of Alabama in Birmingham, where he also directs the antimicrobial stewardship program for the whole of the University of Alabama healthcare system. And he's also currently principal investigator of the mycosis study group education and research consortium, which for those who don't know, is a multi-center international clinical trials and education group. And as I mentioned today, Peter is going to talk to us about invasive candidiasis in the ICU. Before I hand over to Peter, I'd just like to remind you of the last slide, sorry, Jules, of future MycoClinic dates, so that you can put these in your diary. So we have the one today, then there is one program for June and again in September and December of this year. So as I mentioned, if you could submit your questions in the Q&A box at the bottom, and without further ado, I'll hand over to Peter. Thank you.
Thank you so much. It's a real pleasure to be here, and I appreciate those of you who have joined us today. Looking forward to providing this brief presentation and also addressing questions at the end. So without any further delay, let's get started. So today's topic is going to be invasive candidiasis in the ICU. Most of you we'll know that probably half of cases of invasive candidiasis that we record occur in and around the ICU, and so it's a quite relevant issue as this pertains to invasive candidiasis. We know that candidemia, and by extension invasive candidiasis, really is a disease of medical progress. And we know this because really only first started being described in the 50s and 60s, the 1950s and 1960s. And, you know, it became clear pretty early on that there were always associated risk factors generally with this. Very few people were diagnosed with candidemia or invasive candidiasis who didn't have significant identifiable underlying risk factors. And some of these, general risk factors are listed here in this table too, from Mike Fowler's article back in 2016. And these apply to all patients, but in the second bullet, certainly being in the ICU, having a central venous catheter, being on antibiotics, dialysis, TPN, being colonized, other predisposing factors, including pancreatitis, and of course, recent abdominal surgery. These sorts of things seem to be common to most patients who develop this, and they have at least one, usually more identifiable risk factor. So the development of candidemia is usually not a surprise when one looks back at an individual's risks. Now I'm going to go through a couple of cases here and pose a couple of questions, and then we'll get through the rest of this discussion. So the first case, and the one thing about finding cases of candidemia and invasive candidiasis is you really don't have to, you don't have to fabricate these. We always have these around. There's always, sadly, a case or more that present with complications. And this is just one that is a recent person in our hospital. This is a 25-year-old man with Crohn's disease who underwent his first laparotomy for repair of small bowel fistula, and then small segment of jejunum was resected during the procedure. He was febrile post-op, but not particularly ill, undergoing just kind of routine post-op care with empiric treatment with piperacillin and tazobactam for the first 4 days. But then post-op day 4, he develops hypotension, worsening fever, and he's transferred to the ICU. At that time, his white count was 17,000, hemoglobin 10, platelet count 152, and blood cultures are obtained. Vancomycin and fluconazole are added empirically to the piperacillin tazo. His blood pressure stabilizes, but he otherwise remains febrile, and there's really little other change. So then on post-op day 6, which is 2 days later, his blood cultures return positive for a yeast, which is subsequently identified as Candida albicans. So the first question I'll pose is, what's the best choice for antifungal therapy at this time? Remember, he is currently receiving fluconazole 400 milligrams daily. So we'll just give you a few seconds to respond. We'll look at your responses, and then we'll go through what I think is the correct response. Okay, let's see what the responses were. Okay, most of you would begin on account of Candida, no particular one, and 62% of you continue fluconazole but increase the dose. And then the other less common choices. You're all on the right track. My choice would have been an account of Candida. However, in certain circumstances, and especially with Candida albicans, there is, there could be an argument for increasing the dose, although Candida albicans is usually exquisitely sensitive to fluconazole. I think the right answer is an account of Candida. This has been supported in the guidelines, both from the IDSA as well as the European community. And the reasons for choosing an account Candida really have less to do with susceptibility and more to do with just the overall effectiveness and the rapidity of killing with an account Candida. In this hospital course, this was a fully sensitive Candida albicans, as depicted here, sensitive to flu, mica, and amphotericin. He becomes afebrile and is transferred to the surgical floor. Follow-up blood cultures on day 8 are negative, so he has follow-up blood cultures. And now we're at post-op day 12. So 6 days after receiving micafungin, he's ready for discharge home. So then the next question is, what should the patient receive as antifungal therapy at discharge? Continue micafungin, transition to PO fluconazole, obtain compassionate razafungin and give him a single dose prior to discharge, or no need for any antifungals at this time. He's well, he's got negative blood cultures. What would you do? Give you a few seconds to respond to this. Okay, let's see how these answers stacked up. Okay, here again, there is not unanimity, but certainly the vast majority have chosen what I think is the standard approach to this, which is after control of the infection, negative blood cultures, patient clinically well, a susceptible organism or organism that you could predict as being successful, it's perfectly appropriate to transition to oral fluconazole at that time. It may be that there is no need for continued antifungal therapy, but we've not studied that. And so after 6 or 8 days, of antifungal therapy, as in this case. It might have been enough, but studies don't really validate that. It's not a standard approach, and so we've really sort of stayed away from that. And so I think that, we transitioned to PO fluconazole through day 22, which is 14 days from his first negative blood culture. Now, again, the comment about the echinocandins, we'll get into a little bit more detail here in a second. And so the Candida species susceptibility profile, most of you will know this. The echinocandins are generally active across the board against most Candida species. There are exceptions in some situations where parasilosis is resistant or relatively resistant, and certainly with glabrata, well-known resistance there. But the echinocandins are generally quite active against most Candida species. And really, for that matter, fluconazole as well, with the exception of Candida krusei and then susceptible dose-dependent strains of Candida glabrata. The echinocandins really are the treatment of choice for early treatment of candidemia, and that's what's depicted here. And while no single study really underscores this, but if one takes the candidemia studies in aggregate and does a combined analysis, as we and others have done, echinocandins as primary therapy tends to stand out as an important predictor of success, as measured by 30-day overall mortality. And so the consensus among individuals that are expert in this area is that the echinocandins probably should be used as first-line therapy in the majority of patients with candidemia or invasive candidiasis as initial therapy. When to transition then becomes a matter of debate. Some transition very early, the moment you have an identity on the organism, some later, making certain that the blood cultures are negative, patient is afebrile and stable. The beauty of the echinocandins, of course, is they can be given with relative freedom. They don't have many drug-drug potential interactions. They are very safe. Their problem, of course, is that they're only intravenous. One way potentially of getting around that is now the new agent, which has not been approved, but is at FDA currently, and that's razafungin, which is designed as a once weekly type of agent. Studies so far suggest that razafungin is equivalent to standard of care with an echinocandin, followed by step-down fluconazole. So it does appear that razafungin will be an alternative to our current regimens. Not clear where it's going to fall in terms of actual use. Okay. Second case, also an ICU case. This is a 58-year-old woman who had AML, and she is admitted for her second round of consolidation chemotherapy. Since her first round, she's been receiving continuous fluconazole, and that was 12 weeks ago. On day 3 of this admission, she's developed persistent fever, has developed erythema around the Hickman catheter. While initial blood cultures are negative, the catheter is removed because of concern about infection. The fluconazole is stopped, mycofungin is started, and in addition to empiric vancomycin and cefepime. It's day 10 now of neutropenia and fever, continued fever. She's developed this widespread erythematous rash, which is palpable, non-blanching, and non-painful. This rash is depicted on the next slide. These lesions are everywhere. So there are literally hundreds to thousands of these lesions. Easily visible, palpable, somewhat tender. Remember, this patient is neutropenic. Other lab results: serum galactomannan negative. Bronchoscopy she has a cough. I didn't mention this, but she has a bronchial washings that are negative. She does have a skin biopsy, which shows a large collection of neutrophils. No organism seen, but very concerning for disseminated candidiasis. And then lo and behold, blood cultures returned positive for Candida glabrata. Recall she's on mycofungin, has been on this for about 7 days at the time of this blood culture. So the question for this is, for this patient is, what is the best choice of antifungal therapy at this time? Continue fluconazole, begin VORI, begin an echinocandin, or continue the echinocandin, begin a lipid formulation of amphotericin B, or begin a lipid formulation of amphotericin B plus fluconazole. Those are your 5 choices. Okay, let's see what the responses returned. As expected, there's going to be a lot more diversity here. Certainly, continuing fluconazole probably makes a little sense. And I would argue that voriconazole probably doesn't add a great deal to the current regimen. We don't pick up a lot of extra coverage with voriconazole as compared to fluconazole. She's already on an echinocandin, and really by anyone's definition, this is breakthrough. So one of the things that I would like to underscore here is that this is breakthrough candidemia in a person whose Hickman catheter or presumed source has already been removed, and yet she still remains fungemic and has what, for all the intents and purposes, acute disseminated candidiasis with candidemia. And so in a situation like this, it seems that you have burned through 2 of your chief options, that is fluconazole and the echinocandins. And so I think there's little choice but to provide this person with amphotericin at this point, a lipid formulation, and one can choose to add a second agent or not. Generally speaking, our approach has been to just rely on the amphotericin formulation alone. So my answer to this would be a lipid formulation of amphotericin B, which we would administer at 3 to 5 milligrams per kilogram daily. So what happened in this individual? 3 days after being drawn, blood cultures returned positive for Candida glabrata. Fluconazole MICs are very high, 64, and also resistant to mycofungin. So this is a dually or multi-drug resistant Candida species. Lipid formulation of amphotericin B was initiated at 5 milligrams per kilogram. 3 days later, the blood cultures are negative, and the neutropenia, fortunately, it resolves in 7 days, and the patient's discharged home after completing a 14-day course of lipid formulation amphotericin B. So this ended well for this individual. So what I'd like to touch on here is just kind of the emerging resistance issues, and I'll highlight the specific organisms. Candida krusei, we know, is virtually always resistant to fluconazole. Candida glabrata is, though, I think numerically the organism that we worry about the most and we deal with the most, frankly. 10 to 25% of all of our isolates are now frankly resistant to this. Most are susceptible dose dependent, however, and echinocandin resistance, depending on your location, may be a real strong consideration. It has not been a huge problem here at UAB, but we see it a huge problem at many of the cancer centers where echinocandins are used very, very liberally. And so co-resistance, azole and echinocandins, they tend to travel together, and it can account for 10 to 20% of these organisms. We'll speak more about this in a minute. Candida parasilosis all have relatively high MICs to echinocandins, which don't necessarily connote resistance, but there's clearly a higher break point for these organisms. Of more concern, or as much concern, is that many of these are truly azole resistant, and so we can't always rely on fluconazole, voriconazole in these patients. And of course, the less common species now highlighted by Candida auris, but also Gallura mondii and rugosa, may have important intrinsic resistance to the azoles and the echinocandins. So this is an emerging problem really globally. That is, resistance to Candida, resistance to antifungals among Candida species is a recognized, global issue. And it probably takes a face with Candida auris, but one could also look at Candida glabrata as being perhaps numerically more important. The emergence of Candida glabrata has been well documented, and one can see that just in the U.S. alone, over this 2-decade study, how much more prevalent Candida glabrata became in U.S. hospitals. And we've stabilized now so that it constitutes somewhere between 20 to 30% of our isolates, depending on where you are. But it certainly has a foothold. It is firmly implanted as the second most common systemic isolate. Now, this varies considerably from country to country and region to region. If one goes to South America, Candida parasilosis and Candida tropicalis are the two dominant species, and Candida glabrata is much less common. But in our society and in Western Europe, Candida glabrata is the second leading organism in most hospitals. And this is a well-described study. Barb Alexander published this years ago, but it really looked at azole resistance, which was depicted by this is at Duke University Hospital, and this is azole resistance in the top line, the solid line with the diamonds, and it went from around 15% to 30% over a period of about 10 years. But the echinocandin resistance depicted by the bottom lines almost confluent for each echinocandin. It really sort of paralleled that rise, and so that at a certain point, 13% of their isolates of Candida glabrata were frankly resistant to echinocandins. Defining resistance for the echinocandins has been kind of interesting because the breakpoints have shifted, and we have 3 echinocandins, and so it is important to recognize that the current breakpoints are breakpoints by species, and they can be also by compound. So if one looks at the next to the last bullet point, for instance, for Candida glabrata, susceptible is equal to or less than 0.06 micrograms per mil for mica, twice that for anidulafungin and caspofungin. And for each organism, these may be different. So for Parasilosis and Guillermondii, anything less than 2 micrograms per mil for all 3 agents is susceptible. So one needs to look at not only the organism, but also what agent you're going to choose to use in this setting. Echinocandin resistance is not universal in terms of being super important. If one looks at the data from Duke and Pittsburgh and other cancer centers, echinocandin resistance is really, really high. In Europe, it tends to be less, and in population-based surveys, it kind of hovers in the 2 to 3% range for Candida glabrata. So it varies really tremendously depending on where you are geographically, but also what sort of medical center you're in. So if I were to summarize this, I would say that the greatest concern is still azole resistance glabrata. This is not to minimize the emergence of Candida albicans, but everyone deals with glabrata. And so I think the potential emergence of less common species with inherent or acquired azole resistance, i.e. Candida auris, is real. It is true, it can be an assumption that most Candida remain highly susceptible to the echinocandins, but acquired resistance among glabrata strains, as well as Parasilosis, auris, etc., are real. The newer antifungal agents, and there are 3 of them that I've mentioned here, that is ibrexafungerp, razafungin, fosmanogepix. None of those are approved yet, but all have important potential roles in the treatment of infections due to MVR Candida species. So more to come on that. It's an exciting time if one is interested in the development of antifungals. Now, specifically about candidiasis in the ICU, those two patients were in the ICU, but I want to kind of also describe an approach to these individuals, because usually we don't have cultures in hand when we make these decisions. And so many folks, and this is Matteo Bassetti's article from Seminars in Respiratory and Critical Care Medicine from 2019. It's a really nice depiction of how one might approach patients who could have candidemia or invasive candidiasis, and it really assumes that you're going to use some kind of scoring system. You're looking at risk factors, et cetera, and there are many of these out there. There are colonization studies, there are risk factor studies. If you have so many risk factors, that connotes with a certain risk. But assuming that you have a good likelihood of having candidemia, 20 to 25%, then blood cultures are of course done along with non-culture-based tests, and these are not generally available in all places, and some are available some places, and others are just not available. So, for instance, in the U.S., we do not have the Manan Canada products. We have PCR-based test, we have the BDG, and we have the T2, but we don't have Manan, anti-Manan as an example. So this really, it kind of breaks down along your perceived risk using some model, and then is informed then by the positivity or the predictive value of some of these diagnostic tests. Most of these have very good negative predictive value. Their positive predictive value varies because of a lack of specificity. These are generally the types of tests that are available. Of course, blood cultures are the gold standard, but they have a long turnaround time, and they're relatively insensitive. The BDG can, if it's not a send out, if it's run internally, can be done rapidly. Has a very high negative predictive value, but it's not specific. Manan, anti-Manan, again, not available everywhere. And then, we've got the PCR-based methods, et cetera. And these, vary depending on site and the specific product that one is using. I think that if one can just say a word about culture-based diagnoses, the nice things that have changed about culture-based diagnoses of invasive candidiasis and candidemia is that blood cultures are generally better than they were 10 years ago, certainly 20 years ago. Media has improved, the volume that we require is greater. We understand a little bit more about the number of cells that are likely to create a positive, et cetera. But the other thing that's helped enormously has been the availability of MALDI-TOF, which allows, once the organism has grown, the identification in 10 to 15 minutes. And then similarly, once we have actual growth in the biofire, the GenMark, et cetera, PNA fish can offer similar help in rapidly identifying the organism to species level. Among the the culture independent tests, the ones that we rely on in the US are the 1,3-beta-D-glucan. Problem is, it's a send out in most places. So by the time you need that information, it's still 2 or 3 days out before you get the information. Similarly with PCR, T2 Canada comes closest to being immediately available. If it's done in that hospital lab, it's done the same day. It's expensive, so it has a rapid turnaround. It's sensitive. It has varying sensitivity and specificity. We have been using this for years, and I'm not sure that I'm entirely sold on it in terms of its specificity. And then one looks at these types of graphs that really just look at and I've stolen this from Neil Clancy and Hong Lin at University of Pittsburgh, because they've put together these nice predictive values charts based on the likelihood of a person having invasive candidiasis. And I think the important thing to highlight here is that they work best when the prevalence is somewhere between 3 and 10% based on your predictive models. And that's whether you're using a beta-D-glucan or a PCR test or a T2 test. And so their negative predictive value is very good. Their positive predictive value varies a bit, but that is a sweet spot. These are best used when you have a reasonable likelihood of having invasive candidiasis. Another way of looking at these, I won't belabor this. This is for intra-abdominal candidiasis. So I think everyone would argue, everyone would agree that among the common fungal infections, this is an area where I think is the greatest need. So whether people agree with me or not, I think this is where we have the most room to make up. Our blood cultures are insensitive. We continue to rely on those. The T2, other PCR technologies, again, they're only as good as the population you're testing. And I think that, you know, you really have to be careful in interpreting these results, and it really must include the risk of having or the prevalence of disease in that population. Molecular markers for resistance aren't rapidly available right now, unlike we have with GenMark for instance, rapid identification of MRSA versus MSSA. And I think that the other thing that we really lack are biomarkers that help us to assess response. We have that, or we're beginning to see this with the galactomannan for Aspergillus, but not many other biomarkers that allow us to assess response to therapy. Perhaps the histoplasma urine antigen is an exception to that. And so I think that we have a ways to go with fungal diagnostics. I think we've made a lot of progress as it relates to therapies. Now we need to catch up with our bacteriologic and virologic colleagues as it relates to diagnostics. So with that, I'm going to conclude and show you one of my favorite places in the world where my wife and I like to go trout fishing. Thank you so much for your attention. And I think it's time for questions.
Thank you, Peter. That was brilliant. We have a few questions in the chat box. So Harsiman Kaur has 3 related questions. He says, or she says, echinocandins are too costly to be used upfront in developing countries. What would be your best drug choice for empiric and targeted therapy for candidemia in those countries?
Yeah, I think, you know, that it's easy when you're in a developed country to talk about, you know, the best therapy and so forth, but those are really key questions. How does all this translate to resource not rich areas? And I think that you know, in the absence of echinocandin availability, and they are expensive, there's no place where they are cheap to my knowledge, then one is really left with using the azoles. You know, depending on expense, amphotericin might be more readily available, but I think fluconazole is pretty much dirt cheap around you know, around the world. And so again, depends on where you are. If you're in an area where Candida auris is not really prevalent, then higher dose fluconazole. We've seen that fluconazole can be given at doses up to 2 grams a day for patients with cryptococcal meningitis, but it's really not necessary in patients with candidemia. I would think 800 milligrams is a reasonable top dose. if amphotericin were available, and if it seemed that auris is prevalent in this population. If you're in India, if you're in South Africa, if the patient has the right demographics and risk factors, then one starting off with amphotericin until you can exclude auris might be an important approach to that. But you know, I understand that the echinocandins are not generally available in all those places, and sadly, these new agents that are coming, that are being developed, including Ibrexa and fosmanogepix and razafungin, of course they're going to be expensive. So how you know, available will they be to more developing communities? I don't know. So we would hope that those will be made available, especially if we study those. Now, I mean, we are currently looking at an agent. It doesn't have a name yet; it just has a number, ATI 2307, that we're hoping to explore in South Africa and India to treat Candida auris with. But when we do that, the company pretty much has to agree to make that compound available to those communities when it becomes available, and make it available at a reasonable price. So otherwise, NIH will not allow us to explore that treatment option.
Shall I do the next question, Andy?
Yes, go for it, Diddley.
There's another question in the Q&A chat from Dr. Abu, and that's about a central line in the presence of a candidemia. Would you use a cidal agent even if the isolate is fluconazole susceptible? And what is, in your opinion, the best anti-biofilm choice?
Yeah.
Echinocandin, amphob.
Right. This is a good question, because we love to tell people to remove sources, and source control is really big in the management of candidemia. We believe that to be so, and I believe it to be so. I think it's absolutely essential. However, we all know that there are situations where that can't be, where source control is beyond practical. The patient may just not have any other opportunities for access, or they may have a platelet count that's 0 or 5. And so there may be all sorts of reasons why they can't have a central line or a Hickman or some sort of central access removed. So in those cases, fluconazole is not going to be a good option, even if it's susceptible, because it is not a biofilm active agent. And in those settings, both compounds, both the echinocandins and amphotericin, have been looked at. Both have potential activity within biofilm. Both have been used in these antifungal lock solutions, and they both seem to work. I don't have a preference one over the other. I really don't. What we do tell our practitioners in this setting is that, number one, if you have candidemia in a line that cannot go, then we really insist that they treat the candidemia through that line, so as to, in effect, bathe it with the echinocandin or amphotericin, whatever you choose. And then afterwards, make certain that we are leaving the lock solution in there to, you know, sterilize, to even provide more options for sterilization. That assumes that the infection is you know, related to biofilm on the inside rather than the outside of the catheter. So that only works really if the biofilm and the infection is emanated from the internal portion of the catheter. But in terms of choices, I don't really have a strong preference over the echinocandins or amphotericin B. Our choice here is generally an echinocandin, because we use so much of those, they're readily available. And frankly, we just don't have a lot of amphotericin B, not in its conventional form anymore. We just cannot get we can't get our hands on deoxycholated amphotericin B anymore, and that's what we would use in that setting.
shall I go next again? I do. So Jack Doherty has a question. He says he's an ID fellow at Duke, and he's curious if you could speak more to the type and duration of antibiotic exposures that are most important to the risk of Candida infection.
Ooh, that's a good question. Okay. This is the type of question that really takes a detailed analysis in order to come up with the appropriate answer. It's like asking which antibiotics are most likely to give you C. difficile, and I think we know now that quinolones and certain cephalosporins are more likely to, whereas others are not. I don't know the specific data for antibacterials in general, but I will say that and honestly, it's because at least we have not looked at this, and I'm not familiar with this data in detail, but I do think that the broader one goes, the more likely it does seem that we run into problems. And by broader, I mean cephalosporins, carbapenems, etc. Now, I mean, again, the problem with making any of these statements is that it's usually institutional. I can tell you that at our institution, most people who develop candidemia, and we have a lot of candidemia, have all received a broad spectrum cephalosporin or a third or a fourth, if not a carbapenem. And we have 100 of these a year, and the vast majority will have received one of those broader agents. So if I were to speak to UAB's experience, it would be, yes, they've received a broad spectrum cephalosporin or meropenem, with or without accompanying gram-positive coverage. But that's only true here. I don't know what the story is at other places. I can only assume that it's probably similar at other tertiary and quaternary types of hospitals, but a lot of that again will depend on your approach to antibiotic stewardship. What do you restrict? So, for instance, in our hospital, we restrict quinolones. You can't get Cipro without a call to Cipro or levofloxacin without a call to antibiotic stewardship. So, they would play a very small role here, but at other hospitals they may be absolutely important. So I think that's probably the best I can do with that question. What I can say is that all antibiotics can predispose to it. All antibacterials certainly can predispose to invasive candidiasis or candidemia.
Yeah, thanks, Pete. Another question, what is touching on antifungal stewardship from Ruben Arasaratnam. Could you say something about if you use a single or two consecutive beta-D-glucan measurements in the workup of invasive candidiasis, or maybe I can extend a little bit on that because I had a question on that as well. If you have started empiric treatment, when would you stop? Would you stop with a negative blood culture or a negative beta-D-glucan? How are you combining that in an antifungal stewardship approach?
Yeah, and we don't use personally, we don't use the beta-D-glucan for that purpose because it has been, partly because we don't get the turnaround very quickly. If we send a beta-D-glucan today, we might get it in 2 or 3 days. And so the decision needs to be made much quicker. So we just haven't used it in that setting. Many of you have the advantage of having it available to your, on site. If I were using it on site, we would use it again in concert with a predictive model, a clinical predictive model of invasive candidiasis. And we would use it, purely as a marker. I don't think we would use 2 consecutive ones, and we probably wouldn't, I would imagine that we wouldn't use it to follow response to therapy either. I think you really start getting out into the kind of no data or a data-free zone in that setting. As far as empiric therapy and the duration goes, once started, if you made the decision that a person could have invasive candidiasis, the decisions, I don't think we can advocate a one size fits all type of approach. Whatever marker you're using, at this hospital, it may be a T2. Everybody who gets a T2 positive generally gets a course of antifungal therapy. That may be 5 to 10 days, depending on the likelihood of that, being real and whether it's followed up by a positive culture. In the presence of a negative culture, or let's say a beta-glucan alone, and nothing else to come back to confirm it, that is in the setting of a positive, such as a positive culture. I think there is, like I said, there's not a single answer or single kind of cookbook approach to this that addresses all issues. If you have a strong suspicion of the person really fits into a strong category of having invasive candidiasis and has one of these positive markers, then I think many people would feel like they deserve a course of 10 days or so of empiric antifungal therapy, whether or not they have a positive culture. But it really kind of has to be decided at the bedside. Mm-hmm. If the risk is low to moderate, then I think our approach would be to stop at probably 5 days once you've allowed cultures an adequate time to become positive if they're going to.
So I actually had a follow-up question related to Adelia's, if I may, because we use obviously beta-glucan a lot in the UK and rely on it quite heavily, but we find especially in this ITU patient group that it can be a general marker for either sepsis or gut membrane insufficiency. So we do see quite a lot of what we think is probably false positive beta-glucan, which might be dietary glucan leaching out in the circulation. How do you get around that, given that you don't have Mannan availability? Because obviously we would go back and do a Candida Mannan test and say, well, it's not Candida glucan, it's something else.
Yeah, I don't know. I mean, I think we don't have a ton of experience with beta-D. It's funny, we were kind of responsible for getting BDG approved in the US through a lot of early studies that we did, and then it became too expensive and too slow for us to use. So we never really bought in. I mean, we just never really adopted it as a diagnostic test because we weren't running it in-house. I know there are centers that do it in-house, and I think one of the places, Jack may speak to this, but I think Duke offers a beta-D glucan in-house, but there are relatively few in the US that can turn it around that quickly. One of the problems that I've had with the test is that it is so non-specific, and so many things can make it positive. So for instance, it's almost valueless in a person who's on hemodialysis. There are, of course, a host of antimicrobials that can create a false positive. Lack of gut integrity, as you've mentioned, have been a problem with it as well. So I think we are, I'm not the expert on beta-D glucan. I can tell you that we use a lot of T2, and I guess what I would conclude if I were to summarize all these things, my frustration with the Canada Diagnostics is that none of them, in my view, seem to be all that darn helpful in terms of being specific enough and sensitive enough. In our hands, the BD, we get a positive T2, 2 or 3 positive T2s each day, and we follow those patients. They all have blood cultures done either simultaneous or immediately following that. And I would suggest that maybe a third of those are accompanied by a positive blood culture. And so we don't know what to do with these tests, and they're frequently Candida parasilosis. And so we're constantly asking ourselves, what do we do with this information? If at 5 days the patient's well if it didn't really make sense in the first place, and they don't have a positive blood culture, we'll stop the antifungals, because we're using a heck of a lot of antifungals based on positive T2s. Obviously, it can be really beneficial if it's an early sign of what will, an early marker of what ultimately turns out to be a positive case as confirmed by a positive blood culture. But that seems to be the exception, not the rule. And so the question that is left is, are these T2s really markers of early invasive candidiasis without candidemia? Do they reflect a positive, maybe an intra-abdominal abscess, or is it just simply a test that's just too sensitive, just picking up noise in the background? And I think that's the problem with all of these assays. We just don't know what to do with them, and that's why it's frustrating that we have to use so many different assays to try and confirm yet another assay that's not terribly sensitive or specific.
Okay, I think we have time for one or two more questions. There is a comment and question from Dr. Fang Zhao. Great talk, but I was wondering, recently the FDA has approved miltefosine to cure invasive candidiasis. What do you think about that?
Could you repeat the question? I'm sorry, I missed it.
Yeah, it's a comment that the FDA, I have not seen it, seems to have approved miltefosine.
Oh, miltefosine, yeah.
Yeah, to cure for invasive candidiasis, or is it for another fungal disease?
We have seen miltefosine used for certain mold diseases. I've not seen it used for candidiasis. So what I think of it, I'm familiar with some of my colleagues in Australia have used miltefosine for refractory cases of crypto, refractory cases of scedosporium, I believe. And I think that's where it's been used. I'm not aware of it being used in candidiasis. I just can't.
No, good. Yeah. Maybe then another one from colleague Abu. How long should one treat a CVC tip positive culture for Candida, but never a positive blood culture?
Yeah, I don't think anyone knows the answer to that, so I can provide my opinion. What is a positive tip? Okay, well, if you think a positive tip is greater than 15 colonies, then, and of course, it's already been removed, but the patient's not candemic. What is the duration of therapy? What we do is we do not treat that as a candidemia unless at the time we were convinced that this patient was septic with this. It was more than just kind of the routine removal of a catheter that had been in for too long, almost like a curiosity type of thing. So it depends on clinical context. And so if the setting is the patient is clinically septic, this is the only thing we've gotten back that is a tip that's positive for Candida, and all else is negative, then we probably treat that person as if they had candidemia, 10 to 14 days of antifungal therapy. Anything less than that, it would probably be a 5 to 7 day course. Don't ask me to quote any data to support this, because there's none. This is my opinion, and this is what we do, but it's based more on anecdote and just common sense rather than actual data.
We have another question from Dr. Abdul Rasuli in London. He says, do you use fungal-specific blood culture bottles or general bacteriology bottles? And do you think that might change the detection rate of positive cases?
We do not. We use a single bottle. We just use kind of the routine kind of all-purpose blood culture bottle. I don't know how much more one picks up using fungal specific test. I've been unimpressed with the potential value that they offer. Similarly with the isolator bottles, we'll identify the fungus maybe 24 hours earlier, but not ultimately. It's a time to diagnosis more than the absolute positivity or negativity rate of the blood culture. So, I mean, personally, we have not adopted those, and as a routine type of thing. And we work really closely with the micro lab. The individual who runs a micro lab is a pathologist, MD, PhD, who also has just a deep interest in clinical mycology. He runs the clinical mycology diagnostic lab as well. And I guess his bias and mine, we probably feed off each other, has been that they don't offer a great deal more.
Okay, thanks for that. I think I'm looking at the clock, and it's time to wrap up. I want to thank you, Pete, for your excellent talk. There are a lot of compliments in the chat.
Thank you.
So we can see people have enjoyed it. We have gone through most of the questions. So thanks to all of you in the audience who have joined this afternoon. And please keep track of the next one coming up in June. And thank you, Andy, for chairing the session.
You're welcome. Thank you, Peter. Excellent.
Thank you all. Thanks for having me. I enjoyed it.
Bye.
Thank you.